they're not here yet. And yeah, so hopefully we can just start. So you guys are welcome to stop me at any time, just so that we can, start discuss, because it's an important topic, especially if you work in an emergency department. But in any department that you work in, psychosis can present anyway. If you are not prepared, it can be one of the most difficult situations you have to face in your in your area. So that's what we wanted to speak about. So I just wanted to let you guys have a look. This is the basic algorithm, for example, that you can use. All right. So it's the management of a severely agitated or violent patient. Now we're going to go through this thing now. It's just that this is more or less what we're going to go through today. So we're just going to talk about all of these things just in isolation, so that we get an idea of how to manage an acute, aggressive, violent patient that gets into your way. Now, the thing is, what do you do when this patient first comes in? Because it's an extremely scary situation, you know. Now, majority of these patients will come in, they have impaired judgment, they have impaired insight, they're extremely aggressive, they are intoxicated very often. And what happens is that you yourself are in physical danger. I mean, we've had doctors being bitten, we've had doctors being hit, we've had doctors being threatened with weapons. I mean, these are not unheard of things, you know, in any situation. So the first thing is that you need to protect yourself. And if you are a bit senior, then you need to protect the staff that are working with you. So it doesn't matter where you're working. I mean, you could be the only doctor in a particular area. You may not be that senior, but you may be the senior of that area. And when these patients come in, normally the worst thing you can do is cage the patient in, if I can put it that way, all right? Because you've already got a person who is under a psychological strain. And now one of the things, they may have paranoid delusions, hallucination, being told to kill themselves, being told the world is against them. And if you trap them, then it aggravates that, you know, it takes it up to the next level. And as with any human, I mean, if somebody were to come into your home and corner you, you would lash out in whatever way you could, you know, even if you are 4'3" and weigh 30 kilos and you're facing somebody who's huge, you'd still try and lash out, you'd try and protect yourself. And the one thing to understand is that with a mentally ill patient, as much as we may look at them sometimes and think, oh my God, you know, like, how did you end up in this state? Or you may have your own prejudices or biases towards them. The thing is that it is a sick patient, you know. It's just that where the illness is taking place is something that we don't fully understand. We don't really understand all the intricacies of the mind. So if a patient comes into an appendix, you don't, hold them down and physically berate them or verbally berate them if they're not responding to the medication and things like that. So the one thing to understand is that this patient is ill, and you've got to work from that point of view and then go from there. So the techniques that have been talked about before, you know, to ensure staff safety, that's the first thing. And the way that you do that is to just try and keep everybody sort of like at arm's length. Let the person have space and know that if they need to, if they need to go, that they can go. And very often here, we allow the patients to go, no problem. Security will go and bring them back. The family will go and bring them back. But the worst thing you can do is cage them in. Now, of course, it depends on the level of aggression and the level of violence. So if the patient is extremely violent, doesn't have a weapon, at least then you can try and, physically restrain the patient for a little while. But even that has to be taken into consideration that, you know, it's still a sick patient. It's not the patient's not acting or just behaving like that. This is a genuine illness that's going on, all right? The reason why I mention that is I've had people sort of look at patients in that point of view, and it creates such a bias on their side that they don't really approach the patient from the correct side. And you guys are welcome to pop in with any, if you'll have your own horror stories or your own other little things that you all do, it's perfectly fine, all right? So the first thing is to always try and calm the patient using verbal techniques. Now, the best thing to do is let the patient understand that you are not there to cause any harm. The patient needs to understand that you are there to help. Now, sometimes no matter what you say, you cannot get through to them. They have fixed delusions, fixed paranoias, things like that, or they are just so aggressive, so bad pressure of speech that you can't. But with the majority of them, if you speak to them and you ask them, what is going on? Why are you here? What happened? We see the police are coming with you. Why did the police have to bring you? When they understand that you're actually trying to talk to them, quite a few of them, I wouldn't say calm down, but at least start to understand that, listen, I am in a hospital. This is a doctor. Why is this person speaking to me in a good way? But some of them don't respond, but a lot of them do. And if you can get to good side, if I can put it that way. They'll allow you to put up drips, take bloods, things like that. So that's the first thing to use, and it does work quite well. And if you're in a situation, not like an emergency department, maybe an outpatient's department, like a psych outpatient, they always advise you to offer oral care, oral medication first. So if you want to do that, that's perfectly fine. Majority of the time in an emergency situation, you would have to give intravenous or IM in order to get the patient under control, right? So how do you place physical restraints? I don't know if you guys have any idea of how you place physical restraints on these patients, because, and if you do, please, I see somebody's putting on the chat over there. Are we allowed to legally? The thing is, when we say allow the patient to leave, we're not allowing the patient to actually just walk completely out of the hospital. What you're allowing the patient to do is walk out of your department, but under supervision. So normally a security guard will go with them. Somebody would follow them just to see what's going on. You don't want them to abscond from the hospital as well, but you also don't want to trap them within that emergency room or within your setting, wherever you are, because that's when they can become extremely aggressive and violent. So normally what we do is, Brahman, you've worked here, so you know we've got our security guards just sitting outside, but that may not be the situation everywhere. So what we do here is that we allow the patient, if they're really aggressive, they're really not allowing, and they're really fighting, we allow the patient just to take a little walk, and then the security guards bring them back, or the family brings them back. But with a lot of the patients, especially those who are substance induced and things like that, no matter what you do, they're never going to settle down. So that's when you have to go to physical restraint, or a patient with a very severe psychiatric disorder, or extremely violent and things like that. That's when you get to the physical restraint part. Most of the patients who need to take a walk and things like that are those who maybe have got a bit of depression, a bit of mania. They're not necessarily violent and aggressive and attacking everybody, but they just don't want to feel trapped. In other words, you don't want to escalate it to that level. Okay, so placing physical restraints is quite an important thing. So what needs to happen is you are placing this patient under physical restraint, but you don't want them to hurt themselves. If they hurt themselves, then you are liable. Okay. So the way that you do it is, number one, you need at least a minimum of 5 people. Okay. So you need 1 person per limb, and you need 1 person to control the head. All right. Now, no matter how big or scary a patient may look, a single person is able to hold a single limb majority of the time. All right. And the reason for holding the head is just to make sure that you don't actually cause any C-spine injuries, head injuries, things like that. And then you've got to use the specialized restraints if you have them. So the specialized restraints are designed to actually keep, the skin from getting hurt, to prevent the patient from pulling, possibly dislocating limbs, things like that. And if you have seen them, they're lovely. They're leather with cotton. They've got their buckles on them and things like that. So those are actually quite nice. And the head restraint fits completely over the bed. And if you have a specialized psychiatric bed, it's actually got a specialized head restraint that sits over there. It's actually quite a nice thing to see if you've ever seen it, but most of us don't have access to that. I've seen it in 1 or 2 of the private hospitals. So that's when it's needed. Now, the thing is, with any psychiatric patient, the first and most important thing is, do I sedate? If I'm sedating, how much am I sedating? How do I know if I've gone too far? How do I know if I haven't gone far enough? And then the last thing is this really a psychiatric patient, or is there something else going on? All right. So as with any patient, you would do the vitals, you'd make sure everything's okay. You would monitor ABCs and things like that. All right. Then you call security, police, whatever it may be. We have had instances here where we've had to call the SAPS in if they're not here already, to help us control patients and get them under, at least be able to sedate them, if nothing else. Okay. So sedation is a bit of it's a tricky one. All right. So what do you have available? That's the question, because you may work in a situation where you have everything available, or you may work in a situation where you only have 1 available or 2 available and things like that. So it's very difficult to give you a definitive algorithm or definitive protocol and say you must use this, that, and that. The easier thing to do is say, what are your options and what can you use? All right. So let's start first. Now, in the severely violent patient, the suggestion is to use haloperidol, Serenades. All right. Ideally, it should be given IV. And we actually don't start at 2.5 or 5. As much as they've got it here, we normally start at about 10. The reason being, as much as you don't want to over-sedate the patient, but generally when patients come into the emergency department, because of the severity of the aggression, we do end up trying to sedate them quite a bit. So haloperidol, Serenades is always the best one to use immediately. The thing is that it has an immediate effect, not only from a sedative point of view, but also on the psychosis point of view. So the whole point of Serenase or haloperidol is to actually attack that limbic system, attack the GABA system, go into those areas and start telling them, you know what, just calm down. So what happens is the acute hallucination starts settling down, the acute delusion starts settling down, and this allows the sedation also to become a lot more effective. Should that not be available, then you can use midazolam, all right, dormicum. And then here you can see again, they talk about increasing it or increasing it. Okay, now the one that we use at the moment, the one that's the most commonly used would be Ativan, all right, lorazepam, because it's quick acting and relatively short lasting. It only lasts for about 4 hours. So it gives you a chance then to reassess the patient, whether the patient's going to the ward or anything like that. So that's what you use if you don't have Serenase or you don't have dormicum. And majority of the places won't advise you to start with Serenase or dormicum. The thing is, Valium is also an option. Valium, the only issue with Valium is that you have a little bit longer onset. It takes about 10 minutes to really get to its full effect. And it has a 72-hour, what you call it, body time, not half-life, but rather time that it spends in the body. So for 72 hours, which is normally your entire observation period, the patient is now heavily to mildly sedated. So their symptoms may not act up in those 72 hours, but sometimes you have no alternative, unfortunately. So the intoxicated patient, all right, with CNS stimulants, all right. So you're talking about things like cocaine, amphetamines, things like that, or a patient where you don't have any definitive diagnosis. Again, as you can see, they talk about using dormicum, but you can use either dormicum, Ativan, Valium, whatever you have available, and Serenase as well, if you have anything available. Now, what about the intoxication with CNS depression? With CNS depression, you try and avoid the dormicum, okay? So that's what they're trying to point out here. The other thing with the intoxicated patient who's manic, let's put it that way, aggressive, pressure of speech, tangentiality, exaggerated affect, all of those things that you find in an agitated patient, we normally add morphine as well, especially if they've got a history of drug use. So a lot of the dacha smokers, a lot of the wunga smokers, a lot of the heroin users, things like that. Well, no, sorry, not the heroin users, but the other ones. So they come in extremely agitated. They want to fight. They want to be aggressive. If you add a bit of morphine onto your dormicum and your haloperidol, a lot of the time these guys now experience their high. So when they are high, they feel well, and that's when you normally get them quite nicely under control. So that's another little trick that you can do. Now, intoxication with CNS depressants. So, for example, a patient who's used alcohol, opiates, things like that, you're going to try and avoid any of the benzodiazepines or opiates as far as possible. So then you've only got Serenase that's available to you. And what happens if you don't have Serenase? The unfortunate part is that you've got to use one of these. You've got to use Ativan, you've got to use Valium, you've got to use dormicum. Once you start using these drugs, however, it means that you've got to keep a closer eye on the airway. So got to have your patient on a SATS monitor, you've got to have a patient on oxygen, and you've got to be prepared to reverse it if worse comes to worse. So if you've used a benzo, then you would use something like an Nexate. If you used an opioid, then you would be using something like naloxone and things like that. I hope it makes sense. It's it's impossible to teach all of psychiatry in such a short period, but just so you guys get a bit of an idea. So what happens if you've got the known psychotic or psychiatric patient? All right, so these are patients who are known, they've got psychiatric disorders, there's no problem, they're very often on medication. If you go through, and I've been through most of the literature, they all advise something similar to this, all right? The addition of Serenase. Again, we normally start at about 10 milligrams IV, but you can start off slower and go. And eventually you can add a bit of dormicum if you need to. Especially amongst our population, they've been using their antipsychotics for a very long period of time. A lot of them have been on treatment for 20, 25 years or on very high dose treatment in order to get them under control. So most of them don't really respond very well to initial Serenase. But again, I keep on talking about Serenase, but it's been out of stock in South Africa for, I think, about 2 years. So it's not really applicable. So, you would have to sedate them, right, with dormicum, Valium, you'd have to give them Ativan, something like that. But the best thing that you can use is clopixol acufase. So you guys will know of Clopixol depot, which is similar to your Serenase that's being inserted into the system for those who need depot control of their psychotic disorders. Now, Clopixol AccuPhase was specifically developed to work in this acute phase. That's why it's called Clopixol AccuPhase, and also because many of the patients have actually developed resistance to Serenase over a long period of time. So what happens is this gets in there, and having treated patients with this, Clopixol AccuPhase works extremely well. So even if it doesn't sedate them, in other words, they don't become absolutely calm, but what it does do is take them out of that acute psychotic episode. So their acute hallucinations, thought disorders, speech disorders, all of it sort of just melts away like within about 20 or 30 minutes, which is a long time when dealing with one of these patients, but it's relatively quick compared to the alternatives. And then what do you do for a cooperative patient? So a cooperative patient who needs sedation, you can give whatever oral sedation that you have. Very often, and this is just now because this is an emergency department meeting, in the emergency department, we very often don't have access to the oral medication. That's more in psychiatric OPDs, medical OPDs. So generally what we would do is that we would, with a cooperative patient, speak to them about putting up an IV line. We'd give lower doses of Valium, we'd give lower doses of Dormicum, things like that, in order to get them to calm down. I hope that makes sense so far. And if not, yeah, I'll try better. You can let me. And this is a very important thing in elderly patients, renal failures, anything like that, any comorbid conditions. If you feel that the full dose is not is going to cause harm, rather just half the dose. Okay, so why would I not need sedation? So there are certain times when I might want to avoid sedation, because the thing is, we sort of have this bias that if a person comes in with psychotic features, so rapid speech, disorganized behavior, whatever it may be, we tend to automatically go to psychosis as our primary diagnosis. The truth is that psychosis is actually very far down the line. Especially in elderly patients and especially in kiddies, and you're talking about young teens. This is it's very, very far down the list of diagnosis. In fact, it's normally a diagnosis of exclusion. You've got to exclude everything else before you come to this diagnosis of an acute psychosis. All right. So what are the most common reasons for a patient to behave psychotically? So one of the most common is hypoglycemia, but even in hyperglycemic patients with hyperosmolarity, they can also develop a form of psychosis. Hypoxia, very common, very common. So you find the patient SATs are sitting at 87, 86 for whatever reason, and they're behaving as though they are psychotic, very common. A lot of toxins, whether it be an overdose, accidental, non-accidental, or a definitive poisoning, again, they have signs of psychosis. And I'm not sure if you guys were watching the toxicology lectures when we went through aspirin overdose. When you look at an acute aspirin overdose, it has all the features of an acute psychosis: agitation, restlessness, pressure of speech. It's got everything, disorganized behavior. You've got this patient who's walking around. Patients who overdose on tricyclic antibiotics have severe psychiatric symptoms. So don't just jump into psychosis as the first thing. And sometimes it may not be obvious. I'll speak about one case later, and then we'll get to that. Now, in the elderly patients, there's two more common conditions two of the most common conditions that you get that are often mimic acute psychosis. Number one, UTIs. So if you haven't checked the urine and you haven't done a dipstick, you haven't checked this patient. All right. So very often on elderly patients, especially if it's a new onset, because you generally don't develop primary psychosis after the age of 50. It happens, but it's not very common. So if you get this patient presenting after the age of 50 with a primary psychosis, your first thought should be infections. And the most common infection is going to be a urinary tract infection. After that comes hypoxic diseases, so lung diseases and things like that. But the first thing to do is check for that. Now, the other thing that's a bit more difficult to actually figure out are TIAs, small SOLs, space-occupying lesions with seizures, small hemorrhages with seizures, and also temporal CVA, because the temporal CVA doesn't actually cause physical symptoms. You may not have drooping, you may not have hemiparesis and things like that. They often get symptoms that are related to psychosis. So they can have macrosomia, microsomia, delusions. There's a whole lot of things that come along over there. Now, I always advise that if it's an elderly patient and you can't say for sure this is a psychosis, do a CT scan as well, and a contrasted CT at least. And if you don't have the capability of doing it, at least it should be done at some point before this patient is declared as psychotic, you know. So, and unfortunately, in some cases, it's a psychosis associated with dementia, psychosis associated with Parkinson's, in which case you can get a primary psychosis, but at least this should be at the top of your mind. And if there's any abnormality in the vitals, or in your basic checks. So high BPs, low BPs, high heart rate, low heart rate, any of those. SATs are too high, or I mean, SATs are too low, temperature is too low, whatever it may be. Don't consider psychosis as the initial diagnosis. Go to everything else. And if you find everything else is okay, then come back and say, okay. Even a cardiovascular event, an MI, can very easily present as an acute psychosis. So do an ECG, do everything, and then say, okay, you know what, this is definitely a psychosis. Is it always feasible? Not always feasible. Sometimes we have time constraints, equipment constraints. We have so many constraints placed on us in the public system. It's not always possible. But this is where you use what they call your physician gestalt. That means your own instinct, you know. And if your instinct is telling you there's something else going on here, don't just leave the patient and say, no, it's definitely psychosis. But if your instinct is telling you, you know what, I think this really is a psychosis, I've done what I can, but I can't prove anything else, then go ahead with the diagnosis, because the patient is going to be admitted, is going to be looked after. And if something else gets picked up, then at least they can, you know. So that's where we've covered all of these things here, right? And if there's any signs of an underlying illness, psychosis should fall off the, off the table. It shouldn't be considered, all right? So what happens if I've given my patients a whole lot of things? I've restrained them, I have given them all the medication as directed, and they're still not going down. They're still up, they're still fighting with me. What do I do? Okay, now if you've gone for physical restraint, that's very good. Do I hit them with a rubber hammer? I wouldn't suggest it. It would work, that's for sure, but I wouldn't suggest it. So the question is, how far can I go? That's what we need to ask. How far can I sedate this patient? How far can I go? All right. So in the algorithm, it tells us to titrate the chemical restraints to the desired effect. All right. Once you start going higher with your sedation, you need to start thinking about respiratory depression. You've got to start thinking about cardiac arrhythmias, because these are the two most common side effects of these drugs. Okay. So the problem with oversedation, your patient starts having bradypnea, apneic episodes. And in that case, your patient is going to need either reversal or intubation if you feel this patient has got something else. Majority of the patients will settle down quite nicely. You'll keep them on oxygen, you'll keep their SATs up, and everything should be okay. But there are some patients where it doesn't happen. So what else can I use? So once you've given a set stat doses, for example, so you've given your Dormicum, you've given your Valium or Ativan, you've even given Serenase because you've got a hold of it, but you may have even given Clopixol Acufase, but your patient is still not going down. Then your next step is an infusion of one of these drugs to provide a continuous sedation to the patient. Now, this is, remember, to be used in the acute phase. The reason being the patient can't stay on an infusion in a psychiatric ward the majority of the time. So you may, for an hour or two, want to keep the patient while you assess, waiting for bloods, things like that. Now, every hospital has its own infusion protocol. The infusion protocol that we're currently using over here is to give the patient about 5 milligrams of Dormicum an hour, just to keep them moderately sedated. So we add about 50 milligrams of Dormicum to 50 mils of normal saline or Ringer's lactate, and then we run that at 5 mils per hour, either via Dialaflow or an infuser if you have it, even via a syringe driver if you're lucky enough to have it. You know, so what happens is it just keeps the patient calm. You can use morphine as an alternative as well. So it all just depends on the transfusion, on the infusion protocol. But just as long as you're giving something slowly, it should be all right. Now, one of the ones that has been used, and they say it's contraindicated, is ketamine. Ketamine is not a good drug to use in an acutely psychotic patient. However, in a patient not presenting with hallucinations and not presenting with acute delusions, but may, for example, be manic, and bipolar disorder and things like that, but without psychosis, ketamine can be a good drug to use. But I would get senior help before doing that, because technically speaking, it is contraindicated in all of these patients. The other thing you have to consider is, what about the, BBB is blood-brain barrier, right? So all of these drugs have to establish themselves within the brain and get to a therapeutic level to be able to get to the effect. So what causes the blood-brain barrier to be less permeable? That's what you need to ask yourself. So things like cerebral edema, cerebral shrinkage, intracranial infections, intracranial bleeds. So if your patient is not responding, go back and see, before you start them on very heavy sedation, have I missed something? So we'll give you an example. We had a patient here about 2 weeks ago, was handled by one of our doctors here, Dr. Saib, and he did a very good job. I was quite proud of him. This patient, for all intensive purposes, when she came in, she was psychotic. She was screaming. It took about 15 people to bring her in. Pressure of speech, hallucinations, delusions, everything, exaggerated affect, poor insight, poor judgment, disorder, everything that you could write in a mental status exam that would be wrong. She had it, all right? The one thing that she did have that wasn't part of that psychosis was pyrexia. And she had a mild pyrexia. She was about 38.3 degrees, essentially more warm to touch rather than an overt pyrexia. As we started speaking to the family, then we started to realize that she was having a slow deterioration over a day or two. But the actual initiating complaint was actually a mild headache and photophobia. This patient had meningitis. It came back later as a cryptococcal meningitis because she had no neck stiffness, no Brudzinski's, no Koenig's, nothing like that. She was just mildly pyrexia. But we had tried to sedate her quite a bit. We had given her morphine, we had given her Valium, we had given her Dormicum, and she hadn't settled down. And that's when Dr. Saib had a look at the patient and said, what, this could be something else. And it was eventually discovered to be a meningitis. And it was so bad that we even though we decided she's not psychotic, we even tried to sedate her with ketamine so that we could do our lumbar puncture. The blood-brain barrier was so impermeable that we couldn't even sedate her under ketamine. So we couldn't even get an LP because she would jump under full doses of IV ketamine. So that just shows you how the blood-brain barrier can affect it. And I'm sure one or two of you may also now be thinking back and saying, oh my God, I admitted this patient for 72 hours, but this is what happened. But don't stress about it. I'm sure somebody picked it up after that. So this is a sedation assessment tool, and you can always keep this with you. It's a good thing to have just to know where you are. So the question is, what am I aiming for? Right? So we say that if there are 3, this is your patient who you've not achieved sedation at all. +2, your patient is getting a bit sedated, but is still not under control by any means. All right. +1, anxious, restless, but still talkative, but within normal. All right. 0, awake and calm, cooperative and normal. -1, asleep, rouses to voice, slurring or marked slowing. -2, response to physical stimulation, few recognizable words. And -3, no response to stimulation. So the place where you want to be is +1, 0, or -1. Most of us aim for 0 to -1. Once you're in +2 and 3, that's when you know you haven't achieved sedation at all. And once you've gone into -2 and -3, now you have over-sedated your patient. That's how you know you've gone too far. So what do you do if you've gone too far? There's a few options. The most common one is to just reverse the agents that you've used. What I would suggest is if you've used a multiple agents, so for example, you've used an opiate and a benzo, I would actually remove the opiate first. I wouldn't remove the benzo first. The reason being that the benzo may also help you if the opioid withdrawal leads to seizures. In some patients, it can happen. So by removing the opiate first, but keeping the benzodiazepine on board, you're more likely to still keep control. All right. You can do it the other way around, but I wouldn't suggest it. It doesn't work out too well. Okay. Any questions up till now? I've been talking, but it's I'm not sure if I'm making sense or everybody fell asleep on the other side, but anyway, it's not a problem. my physical audience is 0. I don't know where everybody went, but anyway. So thank you to those of you who stuck around. Yeah. So what's our general principles? All right. So we select one sedative, a benzo, all right, and one antipsychotic agent, if available. What, like I say, in South Africa has been OS, all right, and we titrate these to the targeted, what you might sedation, you're right, to yours, what they call the one we saw on the previous slide, all right? So you avoid switching agents and classes as being, as a patient, as it can behave unpredictably as well, all right? Use longer acting agents where possible, all right? So you avoid the roller coaster effect of agitation and oversedation. So that means use things like Valium, Serenase, Dormicum, things like that. But in some patients, because of the time of onset, not necessarily for Dormicum, but especially especially for Valium, Ativan is the much more commonly used one. And you do get a relatively long period. You're talking about 4 to 6 hours. So it's not a problem. And what they're saying is that if you are doing a rapid takedown, so if you are using things like Ativan, Domicum, and all of these in high doses, then you have to be prepared for a rapid sequence induction. All right. I looked everywhere for SECO. I wasn't 100% sure what it meant, but at least I know what this one means. If anybody knows, you can tell me. Sorry, I see somebody came up. So at what level do we want our score to be at? Thanks, Abdurrahman. Let me just go back to that. Sorry, I didn't see it pop up over here. So we want to be at +1, 0, or -1. So that's where we want to be on this on the sedation assessment tool. Sorry. So we want to be in these 3 areas. Ideally, you want to be 0 or -1. But even if you get the patient to +1, we had a patient here yesterday who was at +1. He was a substance-induced psychosis, had taken quite a bit of crystal meth, which is now making its way into Newcastle. And being an amphetamine, he came in, quite agitated, restless, and violent. And once we sedated him, he got to +1. He was even walking around after that, speaking with his parents. He understood that he was going to be admitted. It was perfectly fine. But that's a rare case. Most of the time, we get them at 0 and -1. So I hope that that clears that up. All right. And then, like they say, assessment should occur in a designated safe area of the hospital, available exits, and duress alarms. This is in an ideal world. The majority of us, especially working in a public system, we don't always have access to these things. So you do the best that you can. We like, for example, any regional hospital that deals with these, we're supposed to have a strong room for extremely violent patients. We are supposed to have clearly marked exits. We're supposed to have panic buttons. We have nothing like that. So you work with what you have. Basically, like I say, don't cage the patient in, and have a system that you can use to actually get help. So in our case, we've got our security guard right outside the door. Some may not have that. Some may need to phone somebody, but at least you know what it is and where it's available to you. All right. So assess the situation and patient, including airway, anesthesia, risk to self and others. Basically, make sure that you keep the patient safe. Keep yourself safe. That's the thing at the end of the day. All right. And then exactly, this is how we were talking about restraint and things like that. Yeah, and we avoid prone restraint simply because we're worried about the airway. Yeah, that should help the patient quite a bit. So that's more or less the approach. This is just a little joke to finish off, but just to talk about some of the ethical considerations. So the thing is, from an ethical standpoint, it's, especially if you're working in a busy department, it's very easy to consider everybody who comes in with symptoms of psychosis as having psychosis and immediately sedating, admitting, and putting them in the ward. The thing is, within in medicine, there's a concept called bias. All right. So you have self-bias, external bias, scientific bias, and you also have, what was the last one? Patient bias as well. All right. So psychotic patient, now what each one means. Self-bias. These are biases that you yourself have developed over time. So for example, you've seen a patient prior to this who presented with a small hemoptysis and then died. All right. Now, every other doctor sees a small hemoptysis will maybe just do an X-ray, we'll just do this, we'll just do that. But because of your experience, your bias towards a small hemoptysis, you will want a CT scan, you will want full bloods, you want to intubate the patient. So that's an example of self-bias. Patient bias. Patients can influence you in terms of what they are saying. All right. So the patient can themselves tell you, oh, thanks, man. See, so it's can't intubate, can't oxygenate. Thank you very much. You can see that Abdurrahman is doing anesthetics, that's for sure. Thanks for that. So getting back to the biases. So patient bias. So patients can tell you things that can bias you. So they can tell you, no, listen, I know I've got a heart problem. I've been here. This doctor told me this doctor told me that. Even though a definitive diagnosis hasn't been made, families can come and tell you, no, this patient was definitely on this medication, has presented like this before, when those things have not necessarily happened or have not happened in the way that they say that it's happened. So that's a patient bias or a collateral bias. All right. Then you have a scientific bias and you have colleague bias as well. So scientific bias is things that we've read, things that we've studied. So when I studied, I learned this. So this is what I do for this. Even if somebody comes with newer information, comes with newer source, comes at, no, but I learned this, so this is what I do. So that would be a scientific bias or a medical bias. And then you get colleague bias, for example. So we influence one another. So for example, if I go up to one of my juniors and you say, you know what, this doesn't look like a serious problem, just a mild psychosis, just put the patient in the ward. Now I've biased that doctor because they may have picked up something else that I haven't picked up by not looking at the patient. So when dealing with psychiatric patients, we all have personal bias, and we tend to deal with patient bias. And that patient bias is also based on what we see in the patient. We tend to be biased towards psychiatric patients because 99% of them are psychiatric. It's the 1% that are medical that present the problem, right? Well, actually, it's much higher than 1%, but you get what I'm trying to say. And then we have colleague bias. You have colleagues that are tired, colleagues that want to go and rest, colleagues that want to just get things over with. So it's all these biases that play into it. But at the end of the day, should you get it wrong, the only person who suffers is the patient. So you've got to be conscious of this bias. You've got to think, why am I so quick to call this patient psychotic? And then in your mind, you list out, okay, I can see this, 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 and this. And then say, what am I missing? So I've got a gogo who's 88 years old, who's just come in, and first onset, it doesn't seem likely. Have I tested the urine? Have I looked for signs of a CVA? How many drugs is this patient on? So you've got to go through that whole list of differentials. So, I mean, she may be on 10 drugs at the same time. You know, as an 88-year-old, she may be overdosing, underdosing, maybe a lot of things that are happening. So you've just got to take that into consideration. You've got a 14-year-old coming in who's presenting with acute psychosis, but 14-year-olds are not commonly somebody who presents with that, you know. So is there an underlying intracranial lesion? Is an underlying infection? Is there sepsis? Is there hypoxia? And the same thing with adult patients. You don't bias the patient. You sedate the patient. There's no doubt. I'm not saying don't sedate the patient, but then get an accurate history. Try and do as good an examination as possible, which doesn't take very long. You're talking about 5 to 10 minutes, but at least you give the patient the best chance. What happens is, when you send the patient to the ward, you've now created a bias for the doctor in the ward, because you as a doctor have said, I think this is psychiatric. The doctor in the ward also starts to think, even before they've seen the patient, that this is psychiatric. That's why it's lying in my ward. So you've created a bias to your colleagues, a colleague bias, all right? So you need to avoid that as well. Otherwise, the only person who will suffer is the patient. Should the patient have an underlying medical condition and we don't pick it up, we'll kill the patient. Now, I've used up quite a bit of time. That's the end of it for me. I'm not talking about anything more ethical. I just wanted to point that out because the ethics of bias are something that we can use in a lot of spheres, but they actually pertain a lot to psychiatry. Any questions, anything you guys would like to know? I know it's a boring topic. Hopefully we'll do some exciting ECGs next week, but I just want to know if you guys have any questions, or you guys are happy that you've understood what's going on. It is a very broad topic, and psychiatry takes a good few years to study, even to specialize. So it's not something you can wrap up in like a 45-minute discussion, but I hope it made sense. And I hope you guys understood what I was trying to get across. And yeah, hopefully when you come across these patients, at least you won't be biased towards them, and you'll at least have an approach to sedation and things like that. Because once the patient is sedated, especially in an emergency setting, that's kind of the end of where we leave it with the patient. Once we've decided there's no other medical conditions, we do the basic investigations, we send the patient off to a ward, a 72-hour ward, an observation ward, and then it's normally taken from there. Okay, so everybody happy? Understood? You can give me a thumbs up as well, then I know it's okay. And yeah, can we consider low dose propofol? Yes, you can. The only problem with low dose with propofol is, of course, you know, the raised intracranial pressure that can occur and the low BPs. So it can be used, there's no doubt. I would actually suggest etomidate if you really need to get it up to that point. But if you use a low dose like 20 milligrams, you shouldn't have too much of an issue. We have used it before here. No side effects per se, but it can be used, that's for sure. Etomidate is also a good idea to use. And one of the other ones that we have used before is we've actually gone on to very high dose serenades, up to 30 milligrams, which actually then calms them down quite well, you know. It's not advised to go over 30 milligrams. I've seen one of the specialists take it up to 40, but then of course the side effects started kicking in after that. But definitely you can consider low dose propofol if you've got access to it. There's no doubt. Okay, okay. So I hope everybody's happy with that. And yeah, if there's any more questions, you're more than welcome to message me as well. I see my guys are now tapping me on the shoulder. They just need me for a patient. So we'll end it here. And hope you guys enjoyed it. And next week we'll be talking about an ECG. And like I said, I just want to thank everybody who joined. It's so nice to see you guys come and learn. All right, keep well. And yeah, like I say, any other questions, just message me. But thank you so much for spending your morning with me. And I hope you learned something, and hopefully we can meet again next week. Okay, bye.